What exactly does it mean to be healthy? Is there a measurement, a blood test, or a scan that can tell you how healthy you are? Well, we can measure certain physiology in the body, and there are prediction models to understand future risks, which we'll cover in another video. But what's the definition of being healthy? The World Health Organization defines it as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. This was developed back in the 1940s, when acute illnesses were the main challenge, rather than so many people living decades with long-term conditions, and back when we didn't have as many health screening technologies. And at that time, this new definition was groundbreaking, to move beyond a solely biomedical model and incorporate psychosocial elements of health, and it was a laudable aspiration. The problem, however, as described by the former editor of the British Medical Journal, is that this definition leaves most of us unhealthy most of the time, particularly with a population that lives longer, where aging with chronic illnesses is the norm. Whilst we certainly should incorporate psychological and social factors in our concept of health, the idea that we have the ability to completely eliminate all obstacles in all of these areas seems unrealistic. In fact, even the mightiest superheroes of our imagination wouldn't qualify as healthy much of the time with that definition. Furthermore, such a goal for absolute, complete health with a total absence of any disease can unduly play into medical technologies, industry, and healthcare market growth, irregardless of what benefit it actually brings to individuals, which may contribute to the continued over-medicalization of society. How does illness impact us? We know at least around a third of all adults in the UK live with at least one long-term, potentially serious condition that may impact their life. Are all these individuals perpetually unhealthy? Interestingly, there is very little correlation between many diseases or long-term conditions and an individual's overall quality of life. The relationship is not what we might initially presume. Described in the late 90s as the disability paradox, whilst dependent on psychosocial context, it was found those with serious illnesses or disabilities often rate their quality of life paradoxically much higher, and in contrast to the predictions of those without the condition. This isn't universal across all health conditions, but it is often seen. In many cases, there can even be no difference in the quality of life of those suffering significant illness or disability compared to those without. For example, this oft-cited, although often misquoted study of lottery winners and paraplegics showing smaller differences in self-report than one might expect. This is underpinned by the concept of the hedonic treadmill or hedonic adaptation, a phenomenon coined in the 1970s by Philip Brickman and Donald Campbell, and further explored in the work of Peter Ubel and George Lowenstein, where, following major changes in life circumstances, self-reported life satisfaction and emotional states return back to pre-event baseline levels surprisingly efficiently. This has been shown in numerous cross-sectional and longitudinal studies across many conditions, from stroke to those with colostomies, renal dialysis patients, or paraplegic and quadriplegic individuals. We shouldn't discount the immense suffering individuals can experience with difficult circumstances, but recognize that this is often transitory, with at least some level of adaptation ultimately seen, even with severe disabilities, a testament to the immense potential of the human condition to overcome and accommodate the circumstances. As the Stoic philosopher Epictetus said, it's not what happens to you, but how you react to it that matters. Studies show around 90% of individuals have relatively stable satisfaction throughout their lifetimes. Life events have a surprisingly small impact on measured happiness, although some loss-type events are more strongly associated with longer-term disruption to well-being, such as unemployment, severe disability, or loss of a spouse. Adaptation is often variable and not always complete. Nonetheless, even without complete adaptation, people are usually happier than predicted by those without such conditions, due to potentially several reasons, as described in this paper, from focusing illusions, poor hedonic accounting, or contrast effects. Hedonic adaptation is not fully understood, and happiness or well-being seems to comprise of numerous components, from positive emotions to global life satisfaction. And individuals can respond differently to types of positive and negative events. Personality traits and genetics seem to have a big influence, and we know some people may be more vulnerable to the impact of negative events. Some can have an entirely diminished existence from even the smallest medical issues. Longitudinal and twin studies show life stresses have a variable relationship to well-being. Most people under stress do not become depressed, and equally, stress is not always required for persistent negative emotions. We know some individuals may be more sensitive to adverse life events due to their pre-existing risk factors in genetics or earlier life. Our poor accuracy at predicting how we would feel in different future circumstances, aka affective forecasting, is well recognized and has several implications. In clinical decisions, without recognizing our ability to adapt to different situations, we may make suboptimal, short-sighted choices that do not maximize our long-term welfare. And our inaccurate assumptions can also impact many areas of policy, from how we determine compensatory damages to judging the cost-effectiveness of medical treatments and resource allocation in healthcare. as described in this paper from Polly Mitchell and the works of Paul Dolan and Nobel laureate Daniel Kahneman. In health economics, when assessing the utility score, i.e. satisfaction and functioning of any given health condition, there may be significant discrepancies depending on whether we question patients with that condition or people without it, and also when in the disease course such measurements are taken. Because of hedonic adaptation, when relying on assessments too early or from observers rather than actual patients, we can tend to over-exaggerate the real-world, long-term impact of both the condition as well as of its related healthcare interventions on the actual flourishing and function of individuals. We still don't have any perfect measures to determine happiness, nor do we fully understand what makes up quality of life when it comes to allocating healthcare resources. However, it's clear many illnesses have far less impact on us than most of us would assume. We should also ask, what is a disease diagnosis? Disease definitions are somewhat arbitrary and continually evolving constructs, created and influenced by many stakeholders and committees, including researchers, policymakers, even pharmaceutical companies, to define pathologies for many reasons, such as to guide treatments or even to direct future healthcare and research funding. However, there is a known problem of expanding disease definitions, as described by Ray Moynihan et al., causing more and more previously healthy people to be labeled as diseased. More and more asymptomatic common states of being are classified as diseases. Examples include prediabetes, early-stage hypertension, small vessel disease, hypercholesterolemia, osteopenia, fatty liver disease, polycystic ovarian disease, spinal or joint changes on imaging, an endless list, and in fact, many of today's diseases can have no symptoms at all and minimal clinical relevance. We've often managed to turn a risk of future problems into a disease state, and our health systems regularly employ initiatives, often underpinned by financial incentives, to hunt for such potential pre-disease. Even our concepts of severe conditions, such as heart attacks or dementia, for example, have expanded considerably over recent decades, increasingly based on less reliable evidence of pathology, such as non-specific test results, rather than someone's symptoms. For example, when the definition of dementia was expanded, now including using imaging changes, we jumped from a previous 10 to 30% to now 65% of those over age 80 qualifying for a dementia label. These broader diagnostic criteria could also cause around a quarter of non-demented older people being incorrectly labeled with dementia. We often hear that dementia is on the rise, whereas using fixed measures, it's more likely declining. The well-meaning aspirations for earlier treatment or positive lifestyle changes from expansive testing and diagnoses are unfortunately typically unevidenced. For example, diabetes or hypertension labels given to people deliver little to no behavior change, whilst increasing anxiety. Many expanding disease labels provide little improvement in clinical outcomes and can have greater negative consequences, as medicalizing labels can be harmful, broadly reducing self-reported health, raising anxiety, perceived severity, and a preference towards more invasive management. With current testing technologies, once we approach midlife, almost all individuals could be labeled with an endless list of disease that they don't even have any symptoms from, and subsequently become candidates for low-value medical interventions that often offer little to no benefits. And when it comes to our emotional health, most psychologists would recognize all humans are, at least in some ways, intrinsically flawed. Most of us would qualify for various psychiatric diagnoses, which equally have expanding criteria, at different points in our lives. But would it always be helpful to receive such labels? In developed countries across the board, from cancer to liver disease, we see epidemic surges in prevalence, yet little change in the related mortality of those conditions, which suggests overdiagnosis of non-harmful pseudo-disease. Whilst we must recognize the ongoing challenges of underdiagnosis or misdiagnosis of serious health conditions, both over-detection through increasing diagnostic technologies, as well as over-definition through expanding disease definitions, contribute to the overdiagnosis problem, as well as the subsequent associated over-treatment. This has led to several international initiatives, such as the British Medical Journal's Too Much Medicine campaign, the Less is More series from the Journal of the American Medical Association, or the Choosing Wisely initiative to advance the dialogue around unnecessary tests, treatments, and procedures that offer not only little to no benefit, but also harm. This useful 2016 analysis by Professor David Misselbrook highlights the distinction between diseases, ever-expanding constructs, versus illness, the actual subjective experience of the individual, versus disability, which stems from impairment of function compared to the average human range. These latter two are particularly influenced by psychological and social contexts. Whenever we see health data charts and graphs, we're usually seeing measures of disease, including its even more unreliable surrogate markers such as blood results, rather than measures of people's actual functional flourishing. And our payment mechanisms wrap around these disease-centric codes, creating an economy for sickness that perhaps outweighs the market for wellness within healthcare. Sure, on a population level, we need to codify things with objective measures that can inform everything from public health initiatives to payments and health service planning. But as individuals, if we recognize that so much so-called pathology and disease labels do not accurately describe future risks nor reflect the human experience, then what might be a better way to think of human health? Beyond objective measures of disease states suggested by the WHO definition, concepts of health have evolved more holistically towards the concept of well-being, with a focus on positive psychology and our emotions, i.e. hedonia, as well as our functioning, growth and meaning in life, what the ancient Greek philosopher Aristotle would have described as eudaimonia. Eudaimonia was Aristotle's notion of human flourishing, or the good life. For Aristotle, this was a life of reason and excellence of character. In 2011, at an international conference in the Netherlands, Machteld Huber and colleagues addressed the limitations of the WHO descriptive definition of health and suggested a more conceptual framework with a focus on the ability to adapt and to self-manage, a more functional model of health. Or, as Rocky Balboa put it,
but it ain't about how hard you hit. It's about how hard you can get hit and keep moving forward, how much you can take and keep moving forward.
This is in keeping with how we now recognize individuals can live with long-term conditions, whether significant physical or mental health challenges, yet still maintain a sense of well-being, and that such conditions are not mutually exclusive. A 19th century quote suggests happiness is something to do, someone to love, and something to hope for. In the 20th century, Martin Seligman, inspired by the work of Aaron Beck, who pioneered cognitive and behavioral psychotherapy approaches, further developed the focus on the positive elements in the human experience, in contrast to prior disease-centric models of health. He developed the PERMA model, which has been adopted by numerous institutions globally to encapsulate key tenets of well-being: positive emotion, engagement, relationships, meaning, and achievement. The New Economics Foundation developed a similar model with overlapping themes of 5 steps to well-being, including to connect, to be physically active, to take notice, to keep learning, and to give. Of course, the nuance differs between individuals and cultures, who all hold their own values for what matters the most for their sense of fulfillment. Another pioneer in our thinking around health was Aaron Antonovsky, a medical sociologist who rejected the purely medical model, coining the concept of salutogenesis, i.e. health causing, as opposed to pathogenesis, or disease causing, as he studied how humans manage stress and stay well. Rather than a disease-centric approach of avoiding all problems or loss, a model of salutogenesis recognizes that humans are inherently flawed and ultimately all face crises. This model is instead geared towards growth and achieving one's idealized potential in any given circumstances, analogous to arete, Aristotle's concept of self-development. Antonovsky developed a theoretical concept of a sense of coherence, which comprises of 3 components. 1. Comprehensibility, an understanding of the events in one's life. 2. A belief in having the ability, support, or resources to face challenges, and that they are manageable. Analogous to the psychologist Albert Bandura's concept of self-efficacy, or Julian Rotter's idea of locus of control, where individuals feel capable of influencing their future, shown to correlate strongly with hedonic adaptation. And 3. Meaningfulness, believing that life is interesting, with a sense of purpose, this being the key driver to stay motivated in order to face and overcome challenges. Whilst more validated subdomains have been studied, for example in the salutogenic wellness promotion scale, or the Connor-Davidson resilience scale, which identified key factors in competence, instincts, acceptance, sense of control, and spirituality, Antonovsky's original sense of coherence provides a rough framework for reflection the next time you're facing adversity, to consider where you might require some support in order to improve your resilience, whilst also considering the general tenets of well-being described here: staying active, developing oneself and sense of achievements, reflecting on your understanding of events and sense of meaning in life, and putting effort into social equity and connection with others. We should aspire to nudge individuals towards the type of engagement that improves their sense of well-being. Maybe health checks should focus less on screening for as many pre-diseases or chronic diagnoses as possible, and instead focus on bolstering health-causing salutogenic behaviors, with a healthcare goal focused around the concept of chronic wellness. Whilst in some scenarios medicine has tremendous capacity to influence human physiology, often our ability to significantly change illness outcomes, particularly with many chronic diseases, is incredibly limited. In fact, for many of the most prevalent conditions in the developed world, our common treatments have very small effect sizes, where only a small percentage of those who receive them will actually benefit. And remember, in developed settings, it's broadly recognized that healthcare and medicine only contributes about 10% towards well-being, whereas socioeconomic factors are much more significant determinants of health. As Professor Misselbrook describes, healthcare clinicians should act as biomedical technicians, astutely fixing physiology where possible, or minimizing the severity of symptoms and their interference with function. But clinicians should also recognize their limitations in this regard and not neglect their wider role, almost as secular priests, witnesses, and sickness guides, listening to an individual's catharsis, supporting, signposting, and facilitating people's coping mechanisms to give them the strength to pursue life goals, which may include revision of those goals whilst enduring illness. In summary, we shouldn't necessarily abandon all disease labels. Many hold utility, enabling people to comprehend their condition as well as in guiding medical treatments. And we shouldn't neglect the wider determinants which can affect life outcomes beyond an individual's control. But at a time when we can 3D image our bodies, finding imperfections as small as a few millimeters, ultimately, when qualifying a person's state of health, perhaps we should instead focus on their individual experience, i.e., their hopes, values, suffering, function, and importantly, their personal locus of control, supporting them to understand what is happening in their life, to contend with their obstacles, and to find meaning and purpose. By considering health in this broader way, it may give us comfort that regardless of the inevitable physical, emotional, or social catastrophes of life, most of which we cannot control, that invariably await all of us, perhaps we all have the spirit within us to adapt and move forward in a meaningful manner and to stay healthy no matter what.